Tomaz, thank you for taking the time for a discussion about healthcare IT in Europe, the developments that we've seen in the last 10 years and even more. Better is 5 years old this year, but actually the company itself was just renamed 5 years ago. You've been working in healthcare for over 30 years. And I want to start with your observation of the trends that we see in healthcare IT in general. A lot of problems stem from the fact that legacy software is hard to update. So what does, in 2024, good software mean, and what's great software?
Thank you for the questions, and thank you for having me on this show. So I think in the last few years, what we are noticing is that a lot of the software that was put in during the period of fast digitization is now getting old. So we see a lot of vendors which have outdated software, and of course, as a consequence, a lot of the customers are using software which is way past its lifetime. So COVID accelerated some type of a renewal process, but what I hear from CIOs is that it's extremely hard to find software which they would like, a modern architecture based on some principles which, as you know, we are also advocating for, which is separation of data from applications, excellent UX, UI, and then, of course, modular software instead of a mega suite. And you touched on an important point. It's not just that the software is hard to update or is inflexible. It's extremely hard to put in, even if it's a new project. So we see customers struggling to go live in years after purchasing a product. And this comes from basically two things. One is that I think a lot of the software in healthcare has gotten too complex for its own good. I do not believe that such complexity is needed. It's probably the result of vendors just adding things to existing software instead of coming up with a new approach. And the other thing is, of course, that the software is monolithic, is inflexible, is holding data in the silos of the application, and of course cannot evolve like modern software architectures allow applications to do. So I do believe we're at this inflection point where many CIOs are asking, what should I buy, what should I do, and cannot find good answers.
Mm-hmm. Do we have an example in healthcare where a vendor would slowly sunset a product and parallelly build a new one based on new technology? Because that's one of the challenges, that once you have this huge software that took years to develop, it's really difficult to add new, faster, better technology to that same old technology. And generally speaking, that's the solution sometimes, to actually invest in this new technology in parallel and leave the past behind.
Absolutely. I mean, I guess in some way this is called the innovator's dilemma, right? How do you disrupt yourself? And the problem in healthcare, I think, is that these systems are incredibly hard to replace once they're put into production, which means that the current vendors maybe do not feel the same urgency as in other domains outside of healthcare, where software gets changed much more rapidly. Here, an EHR is almost impossible to replace. So the vendors have a sense of safety that maybe change is not going to happen, or it's going to be too slow. So what we are seeing is that mostly the vendors that have lost a major deal due to the fact that they have older software are the ones who are thinking about the approach you mentioned, which is how can you keep serving customers while at the same time replacing certain functionality with a modern architecture. And yes, we have quite a few examples. The largest example that we have is our partner Tieto in Finland and in the Nordics. They have now about 60 hospitals which are running, I would call a hybrid, which keeps some parts of their previous system, but now has over 800 forms implementing new functionality on top of new architecture inside the same EHR. So I call this a hybrid, and the nice thing about this, it's a gradual approach. It will take them probably 5 years to replace most of the functionality. And you have to remember another thing. So we as a company work with mostly clinical data. So there's a whole other segment of the EHR, which is the patient administration system, which we don't deal with. And of course, it's much harder to replace that because it's always local. It does not go across borders. So it's very difficult to find business cases because most of these deployments are tied to a single market. So you will find vendors that have many solutions because of this problem. And the patient administration system is almost always local or requires a lot of customization. So it becomes a business problem. How do you cover the needs of many countries with very different reimbursement systems, insurance claims, and so on, with a patient administration system? So we have decided to focus on the clinical side, where there's a lot more similarities between countries and the way health system users use software.
Mm-hmm. Looking from the government or regional decision makers' perspective, what they can do if they want to be more modern is that they can mandate standards that need to be used, and then vendors need to adapt. And this is what Catalonia did, and we covered this with Jordi Piera Jimenez from CAD Salute in one of the previous episodes. But I thought it was really interesting, the example that you mentioned when a vendor decided to disrupt itself. Given that, you know, Better is a healthcare IT company, can you imagine that type of transition within your company? What would it mean for the company to actually do that parallel development?
Well, to be honest, we did this the same thing, right? So we did this 10 years ago. So we built a system and started replacing it piece by piece with the new technology. So we are running a few hospitals here in Slovenia. And every iteration, the parts of the code gets replaced with the new architectures based on low code. Mm-hmm. So we're well aware of that, and I think obviously it adds an additional cost, but it prepares you to be ready for the future. So I think this is an ongoing process which must happen in all software companies which are looking to be here for a long time.
Mm-hmm. How do you see the future development of healthcare IT in the upcoming years? Because of the European health data space, there's going to be additional investments for healthcare digitalization in Europe. So can you talk a little bit about that, your expectations, fears, worries?
Yeah, I was just at a conference where we talked a lot about the impact of EHDS, and the consensus among the group of mostly CIOs and decision makers was that yes, EHDS will bring new investment, which is always welcome. But of course, the issues that countries and health systems really have is how to get the initial data in good enough quality and enough data to make clinical decisions before sharing it with others. So I think we haven't solved this problem in a lot of places. We were with some of the most advanced health systems like Denmark, and even they have issues on putting the data together before being able to share it across Europe. So I think, again, if the EHDS directive comes with extra funding and a push towards standardization, it's going to help the local systems. But this has to happen before we think about sharing data abroad. Mm-hmm. And I do believe that COVID did a similar push. In fact, in Europe, we have the RRF, the Recovery and Resilience funding, which is adding another set of funding to digitize healthcare. And then even, I think, cybersecurity breaches are fueling the next wave of investment. There is a big push, for instance, in Italy, to move the entire public sector to cloud for cybersecurity reasons. So there's many initiatives which are bringing new funding into healthcare IT, and I think that's fantastic.
Mm-hmm. If we just go a step back to explain EHDS for those that might not know it, so the idea is that European countries would be able to exchange data and patients would be able to access their data regardless of where they seek care in Europe. This is something that has been an idea for over 15 years probably, and there's been several European projects that have established pilot projects to support how this could be done. And if we look a little bit deeper, we see that on the country or regional levels, there's already a huge challenge of actually exchanging data and enabling patients to get their data within one country. Exactly. So where do you see, so this is something that needs to be solved first before we go more broader, and I'm wondering what kind of examples of good practices are you observing that are solving this issue? So the issue of integrating data, connecting data, exchanging data, regardless of different software vendors, different standards used to get to this single patient record.
Yes, so you are right that I think the countries are struggling to do this at any level, even city level, regional level, country level, and I think it's obvious that before they do that, it's hard to talk about exchange at the level of Europe, at the European level. But EHDS is basically two things. One is the ability of the data to follow the patient across borders for care, and the other is the secondary use, right? So the idea that research could benefit from having data put together, and I think it's these two are quite separate, but both of them rely on having quality data at the level of the patient wherever he or she lives. So I think we're not close to that. There's examples. There are some examples of this being done 10, 15 years ago. We were part of a project called EPSOS, which tried to do this initially. A lot of good came from that, but realistically, I think in practice, the Nordic countries were able to exchange prescriptions, which was already a big benefit. You also have to think about what are the use cases, and some people say, oh, it's tourism, it's medical tourism, it's people moving around. I think the priority should be to do this inside a region or a country, because that's where you get 95% of your care. So unless you can do that, then EHDS is still a long way from being a reality. But I think focusing on the region is what most countries are doing. So we see this in the NHS with the 42 integrated care systems. We see the same in the Nordic countries. We see the same in Spain. We see the same in France now. And the idea is that basically, except for acute care, what is more and more important is chronic care and basically following the patient to where actually this care is given, and it's outside of the hospital in large majority of cases. So what this means is that you need to have basically consistent data across your health region. Mm-hmm. And this is where we focus on now. We have a lot of projects in the UK, obviously the projects in Catalonia, in Wales, in Slovenia are all at this level. And the funny thing is it's almost always a unit of 2 to 3 million. So that's how the ICSs are set up. That's how in Slovenia the national level is set up. We see that this is a unit of enough complexity, but also not overly complex, because what these big countries have found is that to do this in England or Germany or France is extremely difficult. You might be able to do something at the document level, like France has done, or the NHS, but basically to have really high quality, actionable, structured data at the national level is incredibly hard. So they started focusing on regions, and the way they did this is what made, I think, the change possible, and that is that the money starts flowing to the region for them to give it to hospitals, because that gives them influence on what the hospitals buy and makes it much easier to exchange, because they can say, no, you cannot have this application because it will not fit into our ecosystem. So this is a big change, obviously, and we are seeing this happening in other countries. So obviously Catalonia is way ahead. They're actually thinking even further ahead. So their idea is to standardize data wherever it appears. And then, of course, putting that data together is extremely easy. The other countries are saying, okay, let's select a few applications and then try to unify that data through the use of exchange standards. Of course, if you can do the first one, what Catalonia is doing, that's the best, because you have data, for instance, for medications in the same format across the country, and you're very flexible. As long as you have the legal right, you can do many things with that data. But of course, that also means rewriting applications, buying new applications which work in this way, and this is going to take a lot of time. But in other cases, I think the big value of this legislation is the push for standards and the funding. These two, I think, are going to be the biggest benefits from European legislation.
Mm-hmm. I always like to simplify things as much as possible, so it's easier to understand and imagine them. So if we take everything that you mentioned on an example, say we have a hospital that has a legacy system and wants to modernize it, or a country such as the Netherlands, where there's huge discussions around how to connect regions. How do they actually do that? What do they focus on in terms of standards, in terms of technology? So how do they do it?
There's a difference between hospital and region, but in a hospital, especially in Europe, there is no more greenfield. So you would expect them to have an EHR and a patient administration system at least. So as I said initially, that it's incredibly difficult to replace an EHR, almost impossible. So what we are telling customers, and what we see now being adopted in the market, is that they have an EHR, they have issues with flexibility, they cannot add things, they cannot get the data out, they cannot build innovation. So what they do is they put a platform next to that EHR and start developing the innovative applications on that, and then somehow integrate with the old system. One way to do that is to take the data out from that old system through HL7 or any exchange mechanism. And then another thing which they're doing is they're pushing the forms developed on top of the innovation platform back into the EHR. So for the end user, it looks like part of that application. Not all applications can accept that, but mostly they can. There's standards on how to do that. It's called context launch. And this solves many problems. First of all, local teams or smaller vendors can actually start participating, bringing innovation, while the old system keeps the lights on for running the business side of the hospital. And then you can chip away at more and more functionality. And this is not unique to healthcare. If you think about what happened with the ERP space, the enterprise resource planning, which predates the EHRs by at least 10 years. In the 90s, we used to have this best-of-breed approach, which we would take the best possible application and then connect them all together into one system. This created a lot of issues with integration or lack of integration, or users having to use many applications. So we got the mega suite. You can think of that as SAP is the best example, which is already all pre-integrated. And this is what the monolithic systems of today are. But what is happening with these systems in the ERP space is that the marketing department decides to buy Salesforce, even though they have CRM inside SAP, because it's easier to use, it's more user-friendly, they can charge by number of users, it's easy to enter into an agreement, and sometimes the department has their own money, so they start shrinking the core, I call it, right, the mega suite, And then somebody in HR says, okay, I want Workday, and somebody in marketing says, I want HubSpot, and so on. So I believe the same thing is happening now in the EHR space, because there is no way a single company, even if it's Epic, has a monopoly on innovation. There's many innovations that need to happen, and we need to find a way to augment the current EHR with innovation. And I think this bimodal, or we call it postmodern approach, is the right way to go. So this is the care provider. But
I just want to clarify one thing. So we mentioned that a platform gets put on top of the existing systems.
Next to it.
So can we just explain exactly that? So what is a platform in this context? Because we are talking about a platform economy. There's a lot of platforms out there. It's a little bit of a buzzword. So what types of platforms do we have in healthcare, and which one are you talking about?
So I'm talking about something we call a digital health platform. So digital health platform is a term that was defined by Gartner 2 years ago, and it means software which has 3 layers. So there is a data layer, there is an application building layer, meaning low code, so something to help you quickly build applications, and then there's a UX UI layer, which is usually known as a portal. So a portal, tools to quickly build applications, and a data layer. That's what a digital health platform means. Mm-hmm. So this is software. There's quite a few vendors. We are one of these vendors, obviously. We work with something called OpenEHR, which is a format for structured health data, which tries to standardize the data from the beginning. So the idea is, why would different applications store data in a different format, creating all these problems we are talking about when we talk about interoperability, if they could all use the same format? And we find that there's not really a technical reason for not using a common format. It's usually business reasons. So vendors traditionally have tried to lock customers to their data models so that they would have a harder time replacing their software with somebody else's. Now, of course, this cannot benefit the customer. This is actually a vendor issue. And we see now a new generation of vendors who understand this and are trying to offer this added value of having open data to customers. And as we see just recently, last 2-3 years, this is really taking off. Now, if you look at it from a regional or a country level, this is fantastic. Because if you can have data with applications from different vendors in the same format, this creates a much easier path to interoperability in a region or a country. Now,
one question,
sure.
What motivates vendors to actually take this approach? Because as you mentioned, from the business perspective, it's better to just lock customers in because it's going to be more difficult.
I think that's short term. That's short term thinking, because obviously, look, for us as a small company, we cannot compete with Epic and Cerner on functionality. Well, we can't compete with them anyway because we are too small, but a vendor could compete by changing the model and convincing the customer that this is the model they want. And that's what's happening. We now have tenders at Karolinska, in Catalonia, demanding this model. So obviously the market forces the vendors. The fact that some vendors cannot compete at Karolinska because they don't have OpenEHR is a big problem. The same in Catalonia, the same now in Slovenia, and so on. So as the market starts to demand this, the vendors will adapt. The other thing is, and this happened with some of the early adopters, is that, like I said in the beginning, they lost a tender against one of these big vendors. And they saw they could not compete head-to-head with Epic, which is the biggest vendor. So they tried to change the game and convince customers that this makes sense for them, which it does. So obviously the ultimate is market pull. And I think it's the responsibility of the procurers, so governments, hospitals, to think what's best for them. And I think when you explain it, it's quite obvious to them that it's fantastic if all the vendors have the same format so that I don't have issues of putting this data together.
Mm-hmm. We started the discussion by also mentioning the importance of design in healthcare. In the platform, you mentioned the UI layer that's important, and this is really crucial for reducing the burden on clinicians that have to use these solutions. However, if we go into hospitals and look at software, a lot of it still looks like it was built in the 1990s. So,
because it was.
and it's still continuing, the development is still continuing. So what are the trends actually when it comes to design in healthcare? How do companies approach it? How do they make sure that the user experience is something that's at their forefront? Because at the end of the day, it can also impact patient safety. If systems are too different, the users might get confused.
Yeah, you have to understand that most of the EHR software that we use today came from billing systems, right? So revenue cycle management was the driving force because the business case was built around the fact that if you had an electronic health record, you could actually charge for more services because you could identify them and bill for them. So it's quite different, I guess, UI for billing than it is for clinical users. So I think this was usually the next step in the evolution, and unfortunately a lot of the vendors just took the same approach. So we are now seeing new vendors take design seriously because you're right in pointing out patient safety issues, of course usability, burnout, all of these things. But you do have to realize that as we try to collect more quality structured data from clinicians, we are putting a bigger burden on them. So the only way to solve this problem is to collect data in different ways through better design, better UX, new methods of collecting data, either it's voice, video, so on, devices, obviously. So everything needs to change. And I believe design is crucial here because, there's a big difference between, well, I wouldn't say, there's a difference between a user from experience in let's say, telecoms or a bank and in clinical use. What we found is, because we worked in those industries, is usually in those institutions, the boss can tell the users what they're going to use. In healthcare, a lot of times you have to convince the end user, especially the powerful clinicians, and sometimes they have the option of saying, no, I'm not going to use this. And so I think that makes it even more important that you have design which works, which is a good user experience. And of course, don't forget that we are now getting a new generation of clinicians who have lived in a different era and are used to using everything from mobile to online services to great UX. So they demand much more than the previous sets of users.
Mm-hmm. In public systems, sometimes there's not enough funding to actually support all these desires. What I kept thinking, when you were discussing the importance of design and having a good user experience, was that we often don't talk about how the whole hospital architecture and the capabilities that they already have impacts the software. So if you have old computers, if the network is poor, then the software might be great, but it's still not going to work. So what do you, as a vendor, what are you most frustrated about when it comes to a healthcare software, and what do you see or wish it would change in, say, the next 10 years? Because sometimes the answer is better connectivity across the country, and that's a problem that's way beyond healthcare.
Yeah, I'll give you an example. So with a few of our users, we have to support things like Internet Explorer 10, which is already end of life, limited functionality. We cannot move on with the new applications, and that's a real problem. But there's nothing we can do about it. So you're right. Healthcare traditionally has been underfunded on the digital front. With these new fundings, change is coming, and obviously as decision makers see the value in digital, they are willing to invest a little more, but it's quite complex investment. It's not just Wi-Fi. everything from enough computers to new ways of collecting data, device connectivity. It's quite a complex ecosystem, which of course costs a lot of money. So I would add another problem, which I think is even bigger, and that is lack of staff to actually make sure that the implementation is done right. We see this in many markets. Some are better than others. UK seems to be a little bit better than others. They understand the fact that about 50% of the success of the project is the implementation, not the software itself. So change management, things like this. And we are seeing improvements here, but in some countries this is still misunderstood, and they expect the vendor to just install and configure and deal with the end users, which is the wrong approach. So I think having a big enough team, and this is one of the advantages that big vendors have, they can demand a big enough team on the customer side to make sure that the installation is successful and they have enough funding for that. So smaller vendors are at a disadvantage here because the funding for the whole project is usually not enough. And of course, it does not include all the upgrades of all the other systems which affect the efficiency of the software or the usability of the solution. I don't have a silver bullet here. The good news is the prices of equipment are falling. It's becoming more and more powerful. We can do a lot more on devices which we already have, so bring your own device. But I just think it needs, very forward-thinking CIOs to understand the whole, and that's why some of them are successful and some of them are not. We just had a situation in the NHS, I won't name the trust or the ICS, but they were defunded big time. So half the team left, because they saw they could not do any of the projects. And as I understand it, the CEO even asked, why do we need all this digital? So if you have this type of an environment, it's very hard and it's not going to succeed. But that's just one example. We have a lot more positive examples. You mentioned Catalonia. There's a lot of trust in the NHS. Even here in our home country in Slovenia, I think things are now moving, mostly due to pressure from Europe and the funding that's coming.
Mm-hmm. Where do you see the role of AI in all these problems? Because at least theoretically speaking, you could summarize a lot with AI, you could use AI to help with standards. So how do you see that this is going to impact the problems that we were discussing?
So this was the second part of the discussions we had last week in Barcelona. I mean, there were two schools of thought. One is, we have to be very careful, and the other is just do it and let's, solve the problems when they arise. So I think the way I look at it is I separate three different domains for AI in healthcare. One domain is how do you build better applications quicker? This doesn't fall under any European regulation. You can actually be much more efficient in building software and better software at that, using a lot of the AI tools. So here, I think there is no debate. You need to start using it. Things like design to code, things like helping us build solutions quicker, testing solutions. All of this stuff is not different than in any other industry. The second part is efficiency of the care process. So here, I think it's perfectly doable today to improve patient flow, to improve the way we make appointments, to enhance the efficiency of the administrative workers in healthcare. I think there's no issues there, and there's no reason to hold back. Then we get to the clinical use, where, of course, we have a lot of issues because it's many times a part of, clinical decision support, and we get into all these issues, who's responsible and all of these. And here, I don't have a good answer, to be honest, and neither did the people we talked to. But here we have these two schools of thought. I do think we need to test, pilot, and try. Now, whether we put it into full production with disclaimers and people still rely on that, and what happens then, it's not different than decision support from the past, right? Medical device directive. All of these things come into play, and I don't think we have a clear idea how to solve these things. But I do agree with the ones that say we shouldn't hold back. I liken this, so the way I explain it to physicians mostly is one use case which is apparent to me is that, when you go bowling with your child and you put up those side rails so that anybody, even a child, can throw the ball and hit the pegs. That's where I think AI is usable today, to alert on things that could go wrong if the physician makes a mistake. Now, whether it can set diagnosis and things like this, that's another area. I'm not an expert, so I would be afraid to do that. Summarization is also not clear-cut, because what if you forget something in the summary? So as long as you can test and prove that the summarization is 100% correct, you should be okay. But we are now, as a company, in the process of doing just that. But I think, for instance, note-taking, and they call it ambient voice recognition, is a no-brainer, because it produces a document which the doctor would type anyway. He can check for errors. So I would call more that efficiency. It's not even clinical use, it's efficiency. And I see no reason not to start immediately with that.
And a lot of hospitals, especially in the US, have already adopted that. The whole
with good results, as I understand.
Exactly.
I mean, if you go into a hospital and watch the amount of things that clinicians and administrative staff and nurses need to do, I think there's huge room for efficiency gains using new tools. Just the process of scheduling appointments is like, a major hassle for both the patient and the administration. And I think we can do a lot better there. And of course, better utilization of resources is one of the few ways we have to improve waiting times and things like that. And it's a big focus. We all agreed at the conference we probably will not get the amount of people, staff that we will need. So we need to be much smarter with existing resources.
And that refers also to the vendors, because they have to run sustainable businesses, and that's really difficult when you work with governments, when you work with the NHS, that has a specific times when the funding is available, and it can take years for the results to come out. Then somebody can object to the results, and the whole process needs to be repeated, so time flies. How do you make sure that you are sustainable? And what kind of changes do you see in business models that kind of are helping healthcare providers, healthcare vendors to survive?
Okay, I would say you have to make a big distinction between the new vendors, the startups, and the smaller companies, and the existing established vendors. Because for the established vendors, this is actually an advantage. Because of this problem, it's incredibly hard to throw out a vendor. So once you are in a trust, you have, unless you do something very wrong, or cyber attacks are now one of those things, it's extremely hard to replace a vendor and software in healthcare. But of course, that also means it's extremely hard to get in, which is the problem for the smaller companies if you're talking about sustainability of their business. We as a company are now on this, I would say, breaking point where we have enough contracts that we can survive even if a large deal slips, which 3-4 years ago was not the case. So you are right, some deals take a very long time. The extreme example is 10 years. So you need to have a business that survives that. And I would argue that the biggest problem is for the smaller innovative companies to get to that level of sustainability. But once you are there, I wouldn't say it's harder, because it's harder for the newcomers, which as an established company, it makes it easier for you. So it's a blessing and a curse. Once you get over that hump of having enough recurring revenue so that you can sustain the business, then I don't see such a big problem. It's still much slower than other industries, but this, like I said before, has its advantages. But to get to that point is incredibly hard. That's why most startups fail. And I would add another thing which makes things even worse is that most companies do not succeed in going across border with their solutions in healthcare IT. Forget the multinationals, that's a different story, but the smaller companies really struggle because every one of these systems is different. It's mostly public tendering, at least in Europe, which means that you need to have a lot of things in place to be able to even bid. Now you can use partners, which has its own problems, but I think what we hear from investors that is quite, I won't say unique, but quite positive about our company is that we are in 25 markets with the same solution. And as I hear, this is quite rare.
Mm-hmm. So what's your advice, to healthcare startups or companies that do want to scale, that do want to go to different markets? How can they do that successfully? How did you do it, when you first entered a new market? What's your kind of consistent recipe or ingredient?
Well, to be honest, we didn't grow very fast. It's only the last few years that we're growing fast. And before we were growing quite slowly because of these issues that I mentioned. So it came to our advantage that we went after a few markets, right? And in each market we got some deals so that altogether it would be sustainable. If we had focused just on one market, we probably wouldn't be in business today. Now that said, the UK is our largest market. It's about half of our business, but it took 3 years to get the first customer. And probably 5-6 years to become a sustainable business, just this part. So there's no silver bullet. Obviously, there's different types of markets, even in healthcare, right? You have the out-of-pocket, which, or the B2C, as we call it, which is a completely different market, and it has the same dynamics than somewhere else in the world. So, of course, we are in the B2B enterprise market, which I don't know if there's any shortcuts. Of course, if you find the right partner, if you find an institution that is innovative and wants to share a little bit of the risk and pay you to develop for them, that's all things you can do. But each country is completely different. In some countries, we struggle still today. Mm-hmm. And then, of course, there's a lot of legwork and connecting the right people and finding. If you have an innovative product, it's obvious you have to find the early adopters, or even the innovators, as they call them. And those might give you the initial funding, but they will not be the same customers to go after in the mainstream, as they call it. So you need to jump that, it's called a chasm, by focusing on a small or on a focused market and do the best you can there, and finding people who actually would like a solution like that. And I don't think there's any silver bullet. You can use all the social media and everything, but in the end, you have to find these first customers who will trust you enough to take a little bit of risk.
Mm-hmm. Advice again. How do you build trust when you still don't have much to show? Well,
the way we did it was, first of all, in 30 years, we have never failed a project, right? We actually haven't even lost a customer. So obviously, you need to have this, I would say, almost culture of going above and beyond what the customer wants and actually solving their problem no matter what, not looking at the contract, because in public procurement, it's a little bit different. A contract is usually signed by somebody else who's actually not going to use the software. And there's not simple ROI mechanisms as they are in private business to show if something is working or not. It's basically you have to actually make the user satisfied. And that creates a lot of work. So having these early adopters be extremely satisfied to share the message, and because these people do talk to each other, right? So we have some really good advocates of our company in several key institutions now in Europe, and we can use them as a reference. And that's extremely important, because you have to realize that healthcare is risk averse. So we're dealing with serious problems here. Solutions have to be, well, as we say, they must do no harm, which is not easy with software. There's a lot of things that can go wrong. So you actually need people who are willing to take a little bit of risk as customers. Now, when you get over that, it's a different story. Of course, you need to have all the integrations, you need to have all the documentation, partnerships, support for different devices, all of that to make it a compelling offering. But initially, you need to offer something different, which has to be better than what was there before. And you actually need to find that one. Usually the best is a clinical champion. If they can see value in this, that's your starting point.
Mm-hmm. What's your biggest challenge as a company?
Well, it's two things, I think. One is how to grow the company and keep the same culture that I think helps us a lot. And we will need to grow fast because we see a lot of opportunity now. I was talking initially about seeing a void in the market for good solutions. CIOs telling us they do not know what to buy because of the lack of appropriate solutions on the market. And the other one is cybersecurity. As we move to cloud, I think this is a real threat, not just for the customers, but for companies as well. We have seen examples of companies going under because of the cyber attacks. So I think these two are the biggest ones. I'm not worried about are we on the right track, are we providing enough value, all of that I believe we are. But we need to grow the team quickly, and that's never easy. And we do need to figure out or to constantly be vigilant for cyber attacks.
Mm-hmm. As a CEO and as somebody that needs to set the direction of what the company is going to invest its resources in, that requires knowing what's happening on the market and what trends are currently seen in healthcare. So what are you most excited about, and how do you see that healthcare, let's limit ourselves to Europe, is going to develop in, say, next 5 to 10 years?
Healthcare or healthcare IT?
Well, that's an interesting one.
Yeah, it is because, I don't believe that, well, they have to go hand in hand, obviously. I mean, if you move the healthcare IT faster and healthcare isn't catching up, I think it's underutilized. If you do the opposite, I think, we always ask governments, do you have a health IT strategy? And then they will always say, yeah, but we don't have a health strategy yet, so how do we do health IT strategy? So it's obviously they're intertwined, but what I see is some of the stuff we talked about. So moving the focus of care to closer to the patient. In some cases to the home, but to the GP, to outside of the hospitals, which are mostly for acute patients. Then the second one, which actually comes from this first one, is care coordination. I think there's a lot of opportunity to coordinate care as soon as it's outside of the hospitals. In most cases, it's not coordinated. So this is a key. And then the third one is to enable those two, I think, to focus on the data. Because in healthcare, data is different than in other industries. So if you think about just the issue of security, which we talked about before, if somebody steals your bank account data, you open a new bank account. If somebody steals your genomic data, that's it. You cannot change it. So this is one aspect. The other aspect is the longevity of data, right? You would like to have data from cradle to grave. This creates all kinds of problems for applications because none of them will last that long. So if I think about, and obviously that's our mission, is to help solve these problems through data, and to gather this data, we need to build new applications quickly, which brings us into low code. And then, of course, to have them be used by users, we need to provide excellent UX. So it's all connecting to this idea of having the same data across a region, country, sometimes maybe Europe, even though that's still a long way off. But not having these issues when you try to make a consistent care record to get a full picture of the patient's state where you have to go out and get data from all different places, which is totally semantically incoherent. It's really hard to do. So I think, yeah, the focus on data, care collaboration, or coordination, and actually moving or following the movement of care, which is now moving outside of the hospital.
So in essence, a better user experience for the clinicians, for patients, and in essence also for governments. Tomaz, thank you so much for taking the time today and sharing your perspective on the development of healthcare and healthcare IT.
Thank you. Thank you for having me.